Welcome to this video on the BE FREE Orthokeratology lens system. This design is manufactured and distributed in Canada by Precision Technology and Cardinal Contact Lenses. By completing this video, you can become BE FREE certified to gain access to this exciting new product. There are three parts to moving forward with the BE FREE. The first is to become educated and certified. The second is to have access to the software platform, which is provided by Precision Technology and Cardinal Contact Lens. And then the third, of course, is to have your account set up with the labs so that you can phone, email, or order through the BE FREE software platform. The BE FREE lens was developed by the CAT Design Group and is licensed by Precision and Cardinal for distribution in Canada. There are numerous recognizable names that you may know related to orthokeratology, and one can say this design is backed by some of the biggest names in specialty contact lenses in orthokeratology and myopia control. What is orthokeratology? And of course, it's the use of a reverse geometry rigid contact lens worn during sleep that creates a programmed change in the epithelium, giving us a targeted topographical and refractive response. Ideally, orthokeratology should provide freedom from glasses and contact lenses all day long. 20/20 or even better vision should be expected with this treatment, providing crisp, clear vision all day long, and if it's a lower RX, many patients need not wear the lenses every night. A reduced wear schedule may be possible, such as every second night of wear or every third or fourth night of wear for the lower myopes. Higher myopes will need to wear it every night. The BE FREE is not just another orthokeratology lens. It is a platform that provides low and moderate myopia and astigmatism. It provides toric and symmetric landing, but maybe what's most unique about it is it provides both a dedicated myopia control design as well as an adult orthokeratology design. Here's an optimal BE FREE fluorescein pattern. We're seeing a lens that has the appearance of touch in the center, surrounded by the reservoir of fluid that creates your suction force, then your alignment zone, then a healthy edge lift. We see a lens that's relatively well centered. It looks like it should have the ideal position in overnight closed eye wear. So we'll instruct the patient to apply the lenses just prior to sleep. They're worn all the hours of sleep and then removed upon awakening. When we place the reverse geometry lens on eye, that creates a thin little apical clearance of fluid, creating a push force. Then in the mid-periphery, we have this reservoir of fluid creating the suction force. The trapping of that fluid layer is how the orthokeratology effect is created on the epithelium. Post-wear, we see the epithelium compressing in the center. In the mid-periphery, where the reservoir of fluid is thicker, we have a suction or tension force. Then the only part of an OrthoK lens that should land on the epithelium or cornea is in the far periphery. And that's the only place an OrthoK actually mechanically alters eye shape. Now, when we have the ideal lens to cornea relationship, we create this topographical change, giving us central flattening and a reduction in myopia. How long does it take to achieve the orthokeratology effect? Generally, you have 70% of the total effect of that particular lens in one night. But after 7 to 10 days, the lens should begin to achieve its full effect. So by that 10-day mark, the particular lens you've placed on eye is likely to have achieved all it's going to in refractive change and epithelial change. So the important thing is don't rush to conclusions. If after one night things seem to be going in the right direction, then just continue. If you have major concerns over epithelial response or the comfort, then obviously we need to modify the lens. But if it looks like it's going in the right direction, just continue, wait for that lens to achieve full effect. Now there are two critical pieces to the process of orthokeratology. Of course, the slit lamp to monitor eye health, and a corneal topographer is necessary to appreciate the changes we're making in the epithelium. Now, to begin, we want to review patient history. We want a full eye health examination. We want to determine accurately the refraction before we begin, and essentially determine if this patient is safe for contact lenses and safe for overnight contact lenses. The range of patients you can fit with the BE FREE is myopia up to -5, astigmatism with the rule up to 1.5, and against the rule -75. The design is actually built for higher myopia and astigmatism, but this is the Health Canada approved range of the product. The contraindications for overnight orthokeratology are essentially anybody that you would feel uncomfortable fitting into a contact lens, anybody that you think would be higher risk of a lens worn in the closed eye environment. Of course, keratoconus being a corneal thinning disorder, that's probably a case we want to avoid with orthokeratology. Extreme dry eye, herpetic corneal scars, previous refractive surgery is just difficult in OrthoK in adults. And then large pupils are great if it's a child, you get better myopia control, but in adults they tend to have more aberrations and less comfortable with the treatment. So essentially when you approach contraindications, any patient that you don't feel comfortable with contact lens wear, don't consider orthokeratology. Now, how is the lens fit? And really there's a wide range of options. There's keratometry. Corneal topography would add a little more accuracy to that initial lens. But if you have a Medmont topographer, then you really have the best system for use with the BE FREE. Ultimately, any of these products can be used. Keratometry values can be used to design the initial lens. Any corneal topographer can work with the system. And of course, as I said, the Medmont is the preferred and ideal topographer. Now, if you have one single topography capture that's accurate, that would be considered enough to determine the initial lens. Ideally, you always take multiple maps though, and that's to ensure that any one single map may not be in error. By taking multiple images and determining are they reproducible, that helps us to understand if we may have accurate topography. In the case of the Medmont, you can do something called a composite capture, which gives you 100% of the cornea, giving you much of the peripheral corneal shape needed to design the lens, as well as averaging out multiple maps together to ensure we have an accurate capture. So least preferable would be a single topography image. More preferable would be multiple captures, minimum 4, or for Medmont users, the composite. Now, when you look at the two of these eyes, is there any difference? Would one of these cases be better for orthokeratology treatment than the other? And here we see what's called an apical astigmatism, where the figure 8 appears confined to the center of the cornea. On the other side, we see limbus to limbus astigmatism, where the hot meridian appears to run all the way from one side of the cornea to the other. Your apical astigmatism tends to be easier in OrthoK, limbus to limbus slightly more challenging. When we do OrthoK on apical astigmatism, it's much easier to push the cylinder out of the way. Here's the pre-fit corneal astigmatism. Post-fit, most of that hot meridian has been eliminated. We have nice centration of the effect. The blue treatment zone appears centered to the pupil, and we've pushed out most of that hot meridian. When we do orthokeratology on limbus to limbus astigmatism, Now we can create a centered bullseye or ideal topographical effect. However, it's much tougher to push out that hot meridian of the eye. So patients with limbus to limbus tend to respond slightly poorer relative to that cylinder and sometimes the centration. Apical astigmatism is easier and a better candidate. Now let's pull out that certification test questionnaire and go through the first few questions. Question number 1. Which instrument can be used to build a BE FREE lens? Is it A, the keratometer, B, the corneal topographer, C, the Medmont E300 corneal topographer, or D, all of the above? Question number 2. When should orthokeratology lenses be applied? A, 4 hours prior to sleep, B, 2 hours prior to sleep, C, 1 hour prior to sleep, or D, immediately before sleep? Question 3. The orthokeratology effect primarily changes which tissue? A, epithelium, B, Bowman's layer, C, stroma, or D, Descemet's membrane? Question 4. What equipment is required to analyze the orthokeratology effect? Is it A, the acuity chart, B, the slit lamp, C, the topographer, or D, all of the above? Question 5. What is the maximum Health Canada approved range of myopic reduction in orthokeratology? Is it A, -3 diopters, B, -4, C, -5 diopters, or D, -7? Question 6. Which topographical shape responds best in orthokeratology? Is it A, against the rule astigmatism, B, apical astigmatism, C, limbus to limbus astigmatism, or D, irregular corneal astigmatism? Moving on, as we look at this case, both topographically and in terms of the key readings, is this a patient that requires a toric BE FREE lens or a toric orthokeratology lens? We look at the corneal sill and there's 1.25 diopters of corneal astigmatism at around 3 millimeters of the center. That would be considered a fairly low amount of corneal sill, so one wouldn't expect this patient to require a toric. However, we see limbus to limbus corneal astigmatism in the topography. So would that indicate that we have a patient that requires a toric BE FREE lens? Well, let's measure the sagittal depth. If we determine the height of the eye across the flat meridian, the height of the eye across the steep meridian, and determine the difference between them, this patient has 51 microns of sagittal differential, meaning the depth of the eye across the steep meridian is 51 microns deeper than it is across the flat meridian. A OrthoK lens will land across the horizontal, but it will have 51 microns of fluid underneath 12 and 6 o'clock, giving it a fair amount of space to rock back and forth and to decenter. So this patient may be one that requires a toric. In fact, patients over 30 microns of sagittal differential are fit in a BE FREE toric lens. So when the consultant measures the eye shape, they are going to determine when you need a toric based on that 30 micron threshold. So at an 8 millimeter cord, we're going to determine the depth between the flat and the steep, and if the difference is 30 microns or greater, you will receive a BE FREE toric orthokeratology lens. And that's to avoid this type of pattern where the fluid at 12 and 6 o'clock is so thick that the lens is likely to decenter, be unstable, be uncomfortable, and not produce the hydraulic force that we desire it to. So the BE FREE lens comes in both a symmetric shape, and when that symmetric is inadequate in order to align with the peripheral cornea, then the consultants will choose the toric, and that toric will place the alignment appropriate for both flat and steep meridian to give us the centration, the effect, the comfort, and the response that we desire. Now, how do you order BE FREE lenses? There are a multitude of ways to make it simple for your style of practice. You can call the consultant and provide the information that's needed to design that first lens. You can email the consultant the topography and the information required, or you can build the lens through the BE FREE fitting software. As we discussed earlier, there are many ways we can construct the lens from the data provided. Simply the RX and the K readings are enough to design a BE FREE lens. If we have topography data, we would use the RX, the topography information, the visible iris diameter, and the eccentricity value. If we have a Medmont topographer, it automatically provides all the information needed. There's nothing to record. There's no mistakes made in the transfer of data. It's the most efficient of the systems. So to begin, the data that is required is, of course, we need the RX and ideally the visible iris diameter. And that helps you or the consultant to choose the appropriate first BE FREE lens for that particular patient. Custom lens for each eye. The K readings aren't directly used in the manufacture of the lens if you have topography, but it's helpful to know, is this a high central corneal astigmat? Is this a patient that's indicated for BE FREE orthokeratology, or is this a patient that may be too high and contraindicated? Ideally, what we want from the cornea is the apical radius, and that's the curve of the cornea at the apex along the flat meridian, as well as the curve of the cornea in relationship to the steep meridian. With those two central radii values, the lens can be constructed along with some of the other data. Some of that other data includes the eccentricity. So to get the apical radius, you would go into your Topographer software and select an 8mm core diameter, meaning measure across an 8mm diameter. Then you're going to click on the flat button and record the apical curvature or apical radius. Then you'll click on the steep axis button and record the steep axis apical curvature or radius. It's also known as the RO or R0, radius at zero distance from the apex. So it's slightly different from K readings. The eccentricity value is used to determine the depth of the lens along with the apical radii. And what eccentricity does is it measures the rate of corneal flattening of the eye to determine the height of contact lens needed. So we want the eccentricity across the flat as well as the eccentricity across the steep meridian of the eye. To get that information, again, we're going to go to our details window, set our chord of contact or chord of bearing at 8mm, click on the flat button, flat meridian, record the E value, click on the steep button, record the eccentricity of the steep, and now we have all the information we need. Now, what if you don't have corneal topography access? Well, we can use the RX, the flat K, any measurement of visible iris diameter if that's possible, and we used an assumed eccentricity of 0.5. 0.5 because that's the middle of the bell curve in eye shape when measuring eccentricity on normal eyes. So we can assume a normal height of the cornea based on the flat K and that median E. If we have access to topography data, then we can take the RX, the apical radius, the visible iris diameter, and the eccentricity, and we'll be a little more scientific and predictive in determining that first lens. If you have a Medmont topographer, the Medmont software can automatically determine the data required and communicate it with the lab. So the Medmont, again, makes it the easiest system, and it's also one of the most accurate topographers available to design your initial BE FREE lens. If you have the Medmont, what happens is the topography data is imported right into the software. So you simply export those topography maps right and left into the BE FREE software platform, and the BE FREE platform pulls the information that it needs. So there's no worrying about accessing data. There's no worry about transferring the data incorrectly between the topographer and the software. It's all seamlessly done. So the ECP platform is a separate software that's used to design the BE FREE lens. This platform is for the initial lens construction. It's a database that you can refer back to. It provides an order entry system to send the order to the lab and ensure that it's manufactured in a timely fashion. You can check on the order and its status through the ECP software. If you require consultant support, it will also provide you with that communication link. And then if a lens requires any modification or optimization, the software platform is the tool used by practitioners or consultants alike. This platform is not a software you download, which makes it very easy. It's a site that you log into. So it's available on any computer, anytime, from a phone. It can access your patient data wherever you are. If you're at one office and your orthokeratology cases are at a different office, you still have access, and you don't have to worry about backing up the data. So first we begin by entering the patient information: patient name, date of birth, the RX, and any other metrics that we have on the eye. The next step is to import in the information that you have on the cornea from either topography or your Medmont. If you have a Medmont, you're going to click this Open Map Manager to import in the map. So there's very little to do if you have a Medmont topographer. Then the lens specifications are pulled off the topography and automatically populated in the construction of the lens. If you don't have a Medmont topographer and you're using a different brand of instrument, then you simply enter in the flat RO and flat E, and if it's a Toric, the steep RO and steep E. And then the system will construct the BE FREE lens for you. Now, if you desire, you can modify any of the parameters that the system has come up with. If the system wants a symmetric lens based on the eye shape, but you still would like to engage a toric on a relatively low astigmat, you can do that. If you want to fine-tune the RX to be maybe slightly higher or slightly lower, if you want to alter the corneal shape data, all of this is possible. So you can modify the lens parameters as required. Then, once you're done, you can submit this order or click Request Consultation if you want a review by your consultant before the lens is ordered. Once you've submitted that order, it's going to be processed automatically. An email will be sent to the team at Precision or Cardinal Contact Lens. Lens will be processed, it will be manufactured, and sent off to you expediently. Now, once the lens comes in, we're going to apply this lens and evaluate it. So clean, dry hands when handling the lens. Put a few drops of fluid in the bowl prior to application to fill in the reservoir, that deeper reservoir of the reverse curve of the lens. Then we're going to evaluate the fluorescein pattern, the centration, the comfort. You can evaluate visual acuity with the lens on if desired, and if there's any over-refraction, they're both optional. So what we want to do is determine if we're happy with the fluorescein pattern, if we think this is a lens that's dispensable. Is it riding too high? Does it look like it's sloppy on eye? Is it uncomfortable? Is the lens tight with a thin edge lift? Is it riding low? Does it have too much fluid in the center and is likely to be a steep fit? Or do we have the ideal pattern? When in doubt, just dispense the lens. The OrthoK lenses are not meant to work in the open eye environment. They're meant to work in the closed eye environment. So give them a chance to achieve their effect if you're not sure. If you think the lens is grossly high or grossly low and doesn't have any chance of success, then of course contact your BE FREE consultant. When you evaluate the fluorescein, look for predictive signs that the lens may have some trouble in the closed eye environment. In this case, we see a lens that lands adequately across the horizontal meridian, but there's a lot of fluid at 12 and 6 o'clock, indicating we have a relatively symmetric lens on a toric surface. We may require more toricity in this lens to create the ideal outcome. Let's continue with the test questions. Question number 7. What sagittal toricity of the cornea would suggest a toric BE FREE lens is recommended? Is it A, greater than 30 microns, B, greater than 60 microns, C, greater than 90 microns, or D, greater than 120? Question 8. Does the BE FREE design require the measurement of the visible iris diameter? Is it A, yes, or B, no? Question 9. When constructing a symmetric BE FREE lens using topographical data, what information is required? A, the flat meridian apical curvature, B, the flat meridian eccentricity, C, visible iris diameter, D, refraction, or E, all of the above. Question 10. The BE FREE Orthokeratology design uses the ECP software platform to perform the following. A, calculate and order the initial lens required. B, modify post-treatment outcomes. C, acquire consultation support on challenging fits. Or is it D, all of the above? Question 11. When evaluating the BE FREE lens behind the slit lamp, the fluorescein pattern should show which of the following? A, excessive central pooling under the apex of the lens. B, 360 degrees of landing through the alignment zone. C, heavy pooling superior and inferior. Or D, the absence of edge lift. Moving on, after we've done that pre-fitting evaluation, what if you're not sure of the fluorescein pattern? What if you're questioning how tight this lens fit is, or whether this lens has the inadequate toricity for the eye? As we mentioned earlier, if you're in doubt and the patient isn't uncomfortable, if the lens appears reasonably well centered in the open eye environment, if the lens seems to want to perform, it just doesn't look 100% in pattern, then just continue. Because topographically, this will be proved out. In other words, when we send a patient home with the BE FREE Orthokeratology lens, one of 4 things are going to happen. 1, we do it right, we get a perfect bullseye. 2, our lens fits too steep, we create apical steepening called a central island. The 3rd could be a smiley face. The lens rides high and produces a paracentral smile inferior to the pupil. Or the last, the frowny face, opposite of smiley face, where the smile is upside down. We see the frown superior of the treatment zone. So when we do OrthoK, we can only create one of these 4 different things, and each one tells us what we may or may not need to do next. So let's train the patient on application and removal. Ensure that they have clean, dry hands. We'll remove the lens from the case, place a few drops of conditioning solution in the bowl, and teach the patient both application and removal. Then let's schedule the patient for the AM appointment. This can be with the lenses on if it's an early morning appointment, or with the lenses off if it needs to be later in the day. Some practitioners prefer to see the patient first thing in the morning with the lenses on so that they can remove them and observe any signs of staining or any indication the eye is unhappy. Other practitioners feel that it's better to let the patient remove lenses first thing in the morning. They're a little more comfortable that way before they come in to be seen. So it's a practitioner preference. So let's schedule the overnight wear. We'll have the patient apply the lenses just prior to sleep. If there are any concerns prior to that overnight wear, then have the patient return to the office and discuss them with you. Then make sure they understand whether they should remove the lenses prior to their appointment or if they should come in wearing the lenses. In the morning, when we evaluate that patient, if the lenses are on, let's first check for adherence. And let's use this as an opportunity to teach the patient that adherence is normal in OrthoK lenses. What we want to ensure is that we properly release bound lenses prior to removal. You can check lens position, although really it's what does the lens do in the closed eye environment with the lid over top that will tell us most of the story. Now we're next going to remove the lenses, or if the patients come in without them on, we're going to check for staining and check the visual acuity. A full refraction may not be necessary. Now it is expected that some staining will happen in a percentage of patients. We're usually expecting to see grade 1 staining in a small percentage of patients, but anything more severe than that, and we want to evaluate the handling of the lenses, the fit of the lenses, and to determine if any changes need to be made. But just don't be surprised if there is some staining in the first night or two of wear, and possibly intermittently long term. Now the acuity chart can be an incredible tool in that first visit. Start the patient off with their uncorrected visual acuity from the previous day, and then walk them down the chart to show both them and the parents that there is improvement, and that gets everybody motivated and on track to continuing treatment, especially if we have a high minus patient that is only getting 70% effect. We're not getting 100% in that first night. So they may need some understanding of how this lens has improved their vision, but just needs a little more time. Then we want to know, what was the topographical outcome? Is it the ideal bullseye? Is it slightly steep? Is it the central island? Is it slightly flat? Is it the smiley face? Or is it a lens with alignment zone a little on the tight side? Is it the frowny face? Now, this is what's called the Axial Subtractive Map. That compares before OrthoK to after OrthoK and shows you the difference. And what we're seeing is the axial is showing you the blue treatment zone and its position in relationship to the visual axis and the pupil. We want this blue treatment zone to be well centered to the pupil. As we look at that peripheral ring of the treatment zone, determine where is it in relationship with pupil and visual axis. We can also click our cursor in the center and see that this patient had a 3.34 diopter myopic reduction. So the bullseye response means you did everything right. The fit of the lens was ideal, and we have good centration of our effect. The hydraulic force on the epithelium is centered, and it's producing a desirable myopic reduction. It may be we need to slightly increase the effect or decrease the effect in a bullseye response, but the bullseye determines for you whether the lens was centered. So you will use both the axial and the tangential. In the tangential's case, you're using this red ring to understand where is the hydraulic force in relationship to the pupil. In the case of the axial map, we're looking at where the treatment, the power, the effect is in relationship with the pupil. So the axial subtractive map and the tangential subtractive map tell us if we've done things right. Now, if we have an under or over correction, it is very simply resolved by the ECP or the BE FREE software platform. Essentially, all we do is select that we had a bullseye and that we need an extra -1 effect, or that we had 1 diopter too much effect, or whatever the value is, you enter it here for refractive change. But remember, only do this after the lens has achieved full effect. We want to give that lens time to do what it needs to change the epithelium. The important thing is that the BE FREE software will create the changes that we require without us needing deep knowledge of reverse geometry lens construction or how the BE FREE works. We simply need to report our findings to the software and it will make whatever necessary modifications are needed. Here we see the central island response, and this is characterized by the steeper center rather than flatter, and this lake around that island in the middle. This is telling us that our lens may be too high above the epithelial surface, and it's pulling on epithelium instead of hydraulically pushing on the epithelium. Often the central islands ride slightly low, so you may see the blue treatment zone decentered low in relationship with the pupil. Central island patients often have poor vision for the first few hours of wear. So even with your over-refraction, their quality of vision may be reduced, their acuity lower on the chart than you would expect. The good news is central islands disappear relatively quickly. Probably by noontime they're gone. The other thing that's good news about central islands is we just don't see them all that often. The central island means that the lens may be too high in depth, too far off the apex. The alignment zone too tight, can also be inappropriate lens diameter. So discuss this case with your consultant or refer back to the ECP software platform that modifies your BE FREE lens. So what we'll do is import in our Medmont topography and compare it to the library of images. Or if you don't have a Medmont, look at your subtractive map and compare it to the library of mild, moderate, or severe outcomes. In this case, I would guess that the outcome is most similar to a moderate. And if you're in doubt, what should I select? Always choose moderate. It's a big enough jump to make a change, but not so severe that it might make too much of a change. Now, the more common outcome to see is the smiley face, and that's where the blue treatment zone appears to ride high in relationship with the pupil. Smiley face patients often are happy with their vision because we create myopic reduction at the center. In the PM, they may not be as happy because there could be some steepening inside the pupil. Their treatment zone isn't covering the pupil. That creates extra aberrations that they may be sensitive to. Smiley face outcome is best resolved by appropriately centering the lens over the pupil, caused by inadequate sagittal depth, a loose alignment zone, and a superior displaced treatment area that reduces our quality of vision. So to fix it, we simply go back to the ECP software platform where we modify our BE FREE lenses. We import in our Medmont topography, compare it to the library of outcomes, mild, moderate, severe. If we don't have a Medmont, we'll just look at our topography software and determine from that subtractive map which one of these outcomes does the effect appear most similar to. In this case, this patient may have a moderate or severe response. Again, if I'm not sure if it's one or the other, I'm always going to select moderate. That's the median change required to make a big shift in the lens construction. The last outcome you might see is called the frowny face, and it's opposite to the smiley face, where the blue treatment zone appears low. So we are looking at our treatment area displaced inferior in relation with the pupil with a superior frown, and that's why it's called the frowny face. So to resolve a frowny face, it may be sagittal depth slightly off, although generally it's more to do with a tight alignment zone or an inappropriate lens diameter. So let's review all of those things or discuss with a consultant your outcome, and we'll determine the right path forward to modify the lens. The easiest thing to do, though, is to go to the ECP software platform, determine which your topography looks most like, and let the software platform alter the lens. In this case, it looks fairly similar to a moderate response. That's the one I'll select. If I want the tiniest change for any of these outcomes, we may select mild. If we want a massive shift in the parameters, we would select severe. Let's go back to our test questionnaires. And here we have question 12. Following OrthoK lens wear, what topographical response is possible? Is it A, the bullseye, B, a central island, C, smiley face, D, frowny face, or E, all of the above? Question 13. What important AM observation should the patient make prior to removal of their OrthoK lenses? A, check near vision, B, floaters, C, lens adherence, or D, loose lids? Question 14. What is the optimal topographical response following OrthoK lens wear? Is it A, false central island, B, a bullseye, C, limbus to limbus astigmatism, or D, a smiley face? A central island topographical response indicates which of the following? Is it A, an alignment zone too tight, B, a sagittal depth too high, C, a lens diameter too big, or D, any of the above could be the cause? Question 16. A smiley face topographical response indicates which of the following? A, a sagittal depth too high, B, an alignment zone too loose, C, an alignment zone too tight, or D, a lens too large? Question 17. A frowny face topographical response indicates which of the following? A, a lens diameter too big, B, an alignment zone too tight, C, an alignment zone too loose, or is it D, A and or B? An important consideration when you're starting OrthoK is do not rush to conclusions. When you're in doubt about the effect, the topographical effect, or the vision after 1, 2, 3, or 4 nights, don't change the lens and rush to conclusions. Let the lens achieve full effect if things seem to be going in the right direction. Remember that 70% effect is achieved in the first night, but it takes 7 to 10 days to achieve full effect. Your treatment schedule should be 1 night in the custom lens. Evaluate the lens after 1 night of lens wear. Ideally, this should be an AM appointment. Then, after 7 to 14 days, we want to see that the lens has achieved full effect, that the eye is happy with lens wear, the patient's vision is where it should be, We want to determine essentially, are there any modifications that are required? Then the next visit can be a 1-month visit or approximately in that range. And you can do this as either an AM or PM. It's nice to have a PM visit at some point along the way, because then you know, is the lens achieving enough effect to provide the patient with quality vision from the AM all the way through the PM. Then at 6 months, you can check for deposits, warpage, and corneal health, and all ongoing checks in OrthoK should be every 6 months. Some of the considerations related to BE FREE orthokeratology lenses are that they are worn overnight. So we want a very responsible patient. We want the lens properly cleaned, rinsed, and stored. We want the patient to be reliable for their appointments, their checkups every 6 months. We want the patient to avoid using water for rinsing the lenses, for getting any potential bugs on the lens to be worn in a closed eye environment. And it's important to communicate to the patient any pain, redness, or photophobia, and they should see their eye care practitioner immediately. Some of the considerations when you begin BE FREE practice is choose low RXs to start. These are the easiest patients to begin OrthoK treatment with. They usually are incredibly happy with their response even after 1 or 2 nights. So choose the easiest cases to begin, and this will create a momentum in both your staff and in the patients themselves in moving your practice forward and increasing both your myopia control practice as well as your OrthoK practice in adults. A record of 100% speaks volumes. Those low RXs are almost certain to succeed. So having a large cohort of patients that have great outcomes will help the confidence of the staff, of the practitioner, and of your office in the community. When you're taking your corneal topography maps, ensure that your baseline map is your best topography. Spend the time taking a quality initial image in order to get that first lens correct. If we begin with bad topography to start, our initial lens may not be successful and we have to refit. There is always going to be another post-treatment visit for the patient. They will always have another exam coming up. So you don't need to spend as much time getting quality post-treatment responses. It's really the baseline map, the pre-OrthoK map, that's the most important. Because not only does it design the first lens, but you use it in comparison to the post-treatments to determine the topographical response at each visit. The key to success in both orthokeratology and the BE FREE lens design is to achieve the bullseye. Work with your BE FREE consultant to achieve that ideal centration of the treatment. That's going to give you the best effect, the best vision, the best comfort that's possible in the lens. Let's optimize the outcome with the various tools that we have for analysis. Let's check visual acuity and make sure that we're getting the patient where we want. Does the slit lamp indicate our eye is healthy? Is the topography decentered, or do we have a perfect bullseye? And we can use the BE FREE software to help us through this process, or we can always rely on the consultants for assistance. And that leads us to the next important point, is that the labs are there to serve you and to support you. There are trained consultants in topography, in the lens construction, in the post-treatment response to help you optimize the outcomes to create the best possible vision, comfort, and fit for the patients. So use your precision and cardinal consultant as often as you need to create the best BE FREE outcomes. So completing the certification course provides you with number 1, the certification to begin treatment with the lens. Then your sales representative will reach out to you after you've completed the test to provide you with access to the ECP software. The ECP software is the platform used to design, to order, to modify your BE FREE lenses. And support is always available by phone, by email, through the ECP platform from your Precision and Cardinal customer service representative or consultant. Let's complete our last 3 questions. Question 18. Following the initial nights of OrthoK lens wear, what if the topographical response was inconclusive? A, would we continue wear for additional nights and reevaluate? B, modify the lens parameters and refit? C, discontinue OrthoK lens wear completely? Or D, take 2 nights off OrthoK wear and restart treatment? Question 19. What should the OrthoK follow-up schedule be? A, 1 week, 1 month, and then annual checkups? B, 1 night, 3 nights, 3 weeks, and then annual checkups? C, 1 night, 7 to 10 days, 1 month, and then every 6 months? Or D, 1 week, 3 months, and annual checkups? Question 20. What should you tell all OrthoK patients? A, wear the lenses only during waking hours. Surfactant clean the lenses every 6 months. C, report to the eye care practitioner immediately if there is any pain, redness, or photophobia. Or D, replace the lenses every 2 months. If you have any questions following this certification, please don't hesitate to reach out to the staff at Precision Technology or Cardinal Contact Lens. We're happy to answer any questions. Otherwise, we'll be reaching out to you after you send in your certification test questionnaire to let you know how you can begin the process of fitting BE FREE lenses. Thank you very much for your interest and attention.